Participants, please start with it. Okay, thanks.
Recording in progress.
Thank you, team. Very good evening, everyone. I'm Dr. Rajesh Sridhar from the medical team. Today, I'm very honored to welcome you all to this live workshop on where we will deep dive into difficult to treat
Sorry to
and
interrupt, Dr. Ashti. Sorry to interrupt. Presentation mode, please. It is not visible.
Is it visible now?
No.
I think there is some network issues.
Then please start. Restart again if possible.
Yeah. Is my screen visible now?
Yes.
Is it in full screen?
No, it's not in full screen.
No, ma'am.
It's an issue I am sensing from the network. Krishna, if I can share.
Enlarge. Yeah, you can share it or you can enlarge it, the screen. You can
All
zoom
right.
it. Yes. Yes, yes. Now it is fine. And minimize it. Now it is fine. Please continue, doctor.
Thank you. So I'm very honored today to welcome you all to this live workshop on where we will be deep diving into difficult to treat and interesting cases on thrombosis and explore how real world clinical insights from UL can actually transform stroke care outcomes. Now, without further ado, let me kindly introduce our course director, Dr. Sumit Singh. He is the Chief of Neurology at Artemis Hospital, Gurugram, and a former faculty member at AIMS, New Delhi. Dr. Singh he's established the India's first government-run headache clinic at AIMS in 2002 and pioneered the use of botulinum toxin therapies for headache and trigeminal neuralgia in India. He has also authored multiple peer-reviewed publications and book chapters with key expertises in Parkinson's disease and movement disorders. A warm welcome to you, sir, on behalf of Gennova family.
Thank you.
Second slide is not visible, madam. Please, we need to change this. Now it is visible, second slide.
Yeah, slightly delayed. Apologies. Moving ahead, we have moderator Dr. Mohit Anand, sir. He is a consultant neurologist at Artemis Hospital, Gurugram, specializing in movement disorders. He completed his TM in neurology from AIMS New Delhi, followed by a post-TM fellowship in movement disorders at Artemis. His expertises in deep brain stimulation, botulinum toxin therapies, and neurophysiological diagnosis. He has been honored with the Presidential Gold Medal and the Torrent Young Scholar Award in Neurology in 2021. A warm welcome to you, sir, on behalf of Gennova family.
Thank you. Thank you. Happy to be here.
Next, we have our guest speaker, Dr. Karan Sharma. He serves as a classified specialist in neurology and stroke at Artemis Hospital, Gurugram. He holds a fellowship in stroke neurology and is certified by Harvard Medical School in stroke and neurological conditions. He is also a co-investigator in major international trials, including ELAN and Oceanic, and had received multiple World Stroke Organization Diamond Awards in the year 2022 to 2025. Dr. Sharma has published in the Journal of Stroke Medicine and presented at leading international stroke forums. So a warm welcome to you, sir, on behalf of Gennova family. So with this, I would like to hand the session over to our course director, Dr. Sumit, sir. Over to you, sir.
Yeah. So thank you for this opportunity. And thrombosis is something which most of us don't understand. So it might be worthwhile understanding it better with the case presentations because cases tend to stick in your minds. Theory, charts, trials, they are all okay. They are important for academic purposes. But when it comes to management, it's the cases which help the most. So I think I'll ask Dr. Mohit Anand, who's the stroke specialist at our center, to carry the session forward.
Thank you, sir. Thank you for the very kind introduction. As we know that stroke has a very high burden. We see that every 4 minutes one stroke is happening in the country, and most of the mortality is associated within the first few weeks. So if we are able to prevent stroke, then we'll be able to prevent a lot of mortality and morbidity associated with stroke. We know that the golden hour has been stated as 4.5 hours for thrombolysis and 6 hours for thrombectomy. But we'll just see what kind of problems we face on a day-to-day basis, how to go about with the stroke thrombolysis and thrombectomy on day-to-day basis, and what are the indications and contraindication for both of these therapies that we can offer. So let's see by the means of a few cases, interesting cases, that how do we manage stroke on a day-to-day basis. So I would like to hand over the stage to Dr. Karan Sharma, who's a classified specialist with us over at Artemis. He looks after stroke and he'll be presenting a few interesting cases today. Thank you.
Thank you, sir.
Karan?
Yeah, thank you, sir. Good evening, everyone. I am Dr. Karan Sharma. I would be discussing a few interesting cases about stroke. Yeah, my first case is a 77-year-old male with a known case of diabetes, CED post PTC almost 8 years back, and he has hypertension also. He presented to us with the complaints of left upper limb weakness and speech difficulty. Symptom onset was somewhere around 3.5 hours, and on presentation, patient had left upper limb weakness with a power of 3/5 in upper limb, and he was aphasic. NHS on calculation was 7. So immediately patient was shifted for scanning for scan and MRI brain was done, which was suggestive of a right MC infarct, as it is seen in the this image. Right MC infarct with a in the periventricular region it is there, and MR angio was also done, which was suggestive of right M1 MC occlusion. So as patient presented immediately within 4.5 hours, so that is a golden period. So immediately, patient family was counseled about thrombolysis. So patient was thrombolized immediately over there, and intervention team was also informed as soon as possible. And mechanical thrombectomy as an option was also given to the family. Post mechanical thrombectomy, the repeat scan was done, and it showed no bleed, and infarct size was also not progressed. Post MT, TK3 flow was achieved, and patient power also improved to 4/5 in the upper limb, and speech also from a physic it became dysarthric. Repeat scan was done. That showed only infarct region, no further progression, only, and bleed was also not noted. And after 24 hours of thrombolysis, single antiplatelet was started. And further workup was done along with the echo holder, and blood workup was done. So ideally, the criteria for thrombolysis is like patient should be presenting within 4.5 hours. The age should be more than 18 years. Hemorrhage should be excluded by imaging. BP should be less than 185 by 110 mmHg, and NHS should be more than 4. Absolute contraindication for thrombolysis that we should keep in mind is like evidence of ICH on scanning, previous history of ICH, SH, or any AVM. If patient was on has history of warfarin or any chronic liver disease, or patient was any on anticoagulant, or patient INR is more than 1.7, or patient has some history of intracranial neoplasms, or on presentation patient blood pressure is more than 185 systolic and more than 110 diastolic in spite antihypertensive medications. And also if patient has history of bleeding disorder like esophageal varices or peptic ulcer or colitis. Relative contraindications that should be kept in mind is like stroke in the last preceding 3 months and rapidly resolving symptoms, any GI bleed, trauma, or surgery in the previous 1 month, endocarditis or recent MRI aortic aneurysm, or any aortic aneurysm that patient has a history, recent pregnancy or childbirth in the previous 4 weeks, any history of hemorrhagic retinopathy, platelet count less than 1 lakh on examination, and history of any recent bleeding or bleeding disorder, and abnormal INR. So all these things we have to keep in mind. And immediately when we are thrombolizing the patient, we should keep a mind of the check of the blood pressure also. Blood pressure should be less than 185 by 110 mmHg. If it is not, then we have to aggressively manage that blood pressure there and then. Initially, we can give labetalol 10 to 20 mg bolus 1 to 2 minutes. If that doesn't work, we can just try nicardipine also, and we can titrate the dose. If blood pressure doesn't remain less than 185 110 after aggressive management of blood pressure with labetalol nicardipine, we should not administer TPA. Ideal dose, everybody knows, for thrombolysis is 0.9 mg per kg body weight, maximum 90 mg we can give. 10% of the bolus we have to give in a minute, and then the rest 90% we have to give over 1 hour. In case of altiplase, in case of tenecteplase, we can give 0.2 mg per kg as a stat dose. That is a benefit over altiplase. Management of if management of intracranial hemorrhage, if post IVTP, if we encounter any hemorrhage, in case there is any change in the sensorium, any drop in the limb power, slurring of speech, or any drop in NIHS post thrombolysis, we should immediately stop the thrombolysis there and then, and we should immediately lower the blood pressure. Urgent NCCT we should do to rule out the bleed. We should check the fibrinogen levels, and if the fibrinogen levels are low or there is a bleed, we should administer cryoprecipitates that are 8 to 10 units. The criteria for mechanical thrombectomy would be the patient should have a large vessel occlusion on imaging, and time of onset should be 6 to 24 hours. Aspect score should be more than 6, and NIHS should be more than 6.
I think the time of onset should be 0 to 6 over here. The 6 to 24 hours
yes, sir.
is an extended window that we
yes,
have.
Sir. Yes, sir.
Yeah. So,
this is a recent article which was published that thrombolysis can be done beyond 4.5 hours up to 9 hours, which can be guided by perfusion imaging. It was a multi-center trial, randomized trial, controlled trial involving patients with stroke who had hypoperfused but salvageable region of brain, which was detected on perfusion scan. The patient was randomly assigned to altiplase versus placebo between the time gap of 4.5 to 9 hours after onset of stroke, and total of 113 patients were randomized to altiplase group and 112 to the placebo group. It was noted symptomatic ICH reported in the 7 patients in the altiplase group and 1 patient in the placebo group. Thrombolysis beyond 4.5 hours, we can just do by MRI DWI flare mismatch and MRI ASL perfusion imaging also. So I move to the second case, which is a 54-year-old female, which presented to us with complaint of sudden onset right upper limb weakness. There was no facial weakness or slurring of speech noted. Symptom onset was 2 hours only. No comorbidities was known. Only right upper limb weakness was there. That was power was almost 3/5. On imaging, there was bihemispheric watershed infarcts in the frontal, parietal, and temporal regions, and there was no large vessel occlusion seen. As patient presented in window period, she was thrombolized with tenecteplase. The same day, echo was done, and it showed echogenic mass of 4.4 into 2.9 centimeter, which was myxomatous in appearance, possible myxoma. This was the imaging of the patient. It showed bilateral hemispheric infarcts were there in the frontal, temporal, and parietal regions. This is the ADC of the same patient. The same day, patient was cardiology reference was taken, and patient was transferred to the cardiology unit for further intervention. Ischemic strokes are of 2 types, thrombotic stroke and embolic stroke. So this was an embolic stroke. Thrombotic stroke happens when a clot that is developed in an artery, it forms over an area of plaque buildup, which is known as atherosclerosis. And thrombotic strokes are further of 2 types, large vessel thrombosis and small vessel thrombosis, which we call as lacunar strokes. This is an image of a large vessel thrombosis, like the left MC superdivision infarct. Embolic stroke occurs when blood clot is formed elsewhere in the body, often in the heart, or travels through the bloodstream and lodged in the brain artery. Possible atrial fibrillation or flutter, and after heart valve surgery, this image shows bilateral hemispheric infarcts, mainly in the watershed areas. possible embolic stroke only. Now move to my third case, which is a 50-year-old female, which presented with a word finding difficulty. No limb weakness or no facial weakness was noted. Symptom onset was 2 hours. She had a history of hypertension, diabetes, and NIHS was 2. In this case, there was a low NIHS, but it was a word finding difficulty. So basically, a disabling stroke only. So we moved ahead and imaging was done. Right MCA, superior division infarct was there, as seen in this image. MRNG showed no large vessel occlusion, and since the stroke was a disabling but NHS was low, she was thrombolized. And post thrombolysis, next day, further workup was done. Echo was showed EF of 50-55% with a dilated LA. Next day, the repeat imaging was done post thrombolysis. That was did not show any bleed, and patient was started on single antiplatelet, and patient symptoms also improved. So the thrombolysis in a low NIHS, the ASA guidelines recommend that mild stroke severity with a low NHS and no disabling symptoms should not receive alteplase. But the recent PRISM trial was done, which randomized patients compared IV thrombolysis with alteplase and versus aspirin. PRISM trial was halted early because of some technical issues, but the acute ischemic stroke patient with a low NHS of 0 to 5 were enrolled in this case, and unlikely there was many benefit from the treatment of alteplase versus comparison to aspirin in low NHS patients. However, it is seen that in this case, the patient with a low NHS but disabling, she was benefited with thrombolysis. Thank you.
Thank you, Karan. Very well elaborated cases. So I would like to just discuss a few pointers that you told about the extended thrombolysis window up to 9 hours. That is because of the extend trial, but there is also the wake up trial in which the last known onset is not known, and we can extend the window in case of wake up strokes even up to 24 hours in that case. And we also see that there is the diffuse and the dawn trial, which will increase the thrombectomy, mechanical thrombectomy window even beyond 6 hours, even up to 24 hours, right?
Yes, sir.
And in the second case, we saw that we had a cardioembolic stroke. So the patient that you showed was had a myxoma in
Yes.
the echo findings, but sometimes myxoma is mixed up with infective endocarditis. So in a patient of infective endocarditis, we should be very cautious in thrombolysis because that is a relative contraindication in case of yeah. So
Yes, sir.
if a cardioembolic stroke is happening in the background of fever, high grade fever, altered sensorium, if there's any history of RSD also, then we should be very cautious in thrombolizing a cardioembolic stroke as well. It has implications in the further management as well, because if it is a large vessel occlusion, then the patient can be taken up for mechanical instead of thrombolysis as well, right?
Yes, sir.
And the third case was also discussed very well. It was a case of low NIHS. So usually we say that if the NIHS is less than 4, then we don't need to thrombolize. But if the NIHS is only measuring one parameter and that one parameter is very disabling for the patient, like a right hand grip weakness or a aphasia, which is debilitating for the patient, then we should be going ahead for thrombolysis. That is what we are following in our routine practice right now.
Yes, sir.
Very well elaborated cases. Dr. Sumit, sir, would you be adding anything to the discussion, sir, please?
No, I think very well elaborated cases. If there are any questions from the audience, we'll be delighted to discuss.
Also, currently no questions from the audience.
Sorry?
Currently no questions from the audience.
There is one question, Kalpita. Just now we have received one question. I'm just reading the question, sir. What was the time required for MRI brain and angiography? Why MRI was preferred over NCCT brain plane? This was the only question, sir. Just now received.
Mohit?
So the benchmark for imaging from door to imaging is 25 minutes. And usually in our center, the imaging time is less than 15 minutes. So I think in this case also, the imaging time must have been less than 15 minutes. The part that we have shifted to MR based protocol because ours is a tertiary care center. The CT based protocol is more suited for a primary or a secondary care center where the option and availability of MRI is limited. So in our center, we have a MRI based protocol not to waste any time. If the patient is showing ischemic stroke, why do we have to wait for a CT and then get an MRI done? So in our center, we are following an MRI based protocol, and if the patient is in the extended window, then we prefer, in fact, to get an ASL or a perfusion study also along with the MRI. So in stroke, we know that time is everything. So no need to waste any time for CT. I think if tertiary centers are capable of doing MRI, then the patient should be straight away shifted for a MR based protocol instead.
Also, it's important that if you want to look at the large vessels, then you'll have to do a contrast enhanced CT angiography, which would require creatinine, which will further require timing. So here, what we do is that if we want to look for large vessel occlusion, we do a MRI and a MR angio of the brain almost in the same setting, which hardly takes 4 to 5 minutes. So that is a faster way of evaluating patients, and it also directs us about the further line of treatment, whether it will be only thrombolysis or it will be also requiring for intervention.
Yes.
Thank you. Thank you, sir, for answering the question. No other questions from audience, sir.
So if there are
Dr.
no
Vance,
questions, I
yeah,
think we
please.
can close the session.
Yes, sir. So, definitely the discussion went quite well, and the workshop might have sparked real meaningful discussions among the audiences also. I won't take much of your time. On behalf of the entire organizing team, I would be very, very honored to tell you that we have around 70 audiences with us join this webinar. And so, thanking all of you. Thank you, our course director, Dr. Sumit sir, our
Thank
moderator,
you.
Dr. Mohit Anand sir, and your
Thank you.
invaluable insights and discussion throughout this shows very big leadership throughout the session. Deeply grateful to our distinguished speaker, Dr. Karan Sharma sir.
Thank
Your expertise and contribution definitely have enriched many understanding in a different way towards this case. So let's continue to collaborate further and innovate as we work towards improving stroke
Mhm.
care in day-to-day life and transforming healthcare together. Thank you all and very good night.
Good night, everybody. Bye.
Bye.
Thank you.